everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please, we have a full house here. Please turn off your cell phones. Thank you. Please leave your questions till the end. For those online, you can enter them in the chat. Please answer a brief survey that will be sent to you immediately after the rounds. This will let us know that you were present today. And finally, I'd like to call on our speaker today is for the Division of Medical Oncology, and I'd like to call on the Chief of Medical Oncology, Dr. Nathaniel Buganim, to introduce our speaker. Nathaniel, are you there?
I'm happy to present Dr. Jamil Asselah, who's been with us for over 15 years. He's an active member of the clinical trial group here at the Medical Oncology Department. He does breast cancer and hepatobiliary. He's been instrumental in moving novel therapies to patients, including antibody drug conjugates, and more recently has been our liaison in order to get a patient portal in the oncology department called Luna. And while he was doing so, got a big interest in AI and how it can help us both in oncology and medicine. So, without further ado, Jamil, the floor is all yours, and we're all excited to hear what you have to tell us.
For this presentation, the learning objective. By the end of this lecture, you will be able to describe the current AI landscape in internal medicine, to identify practical AI use cases that augment clinical reasoning, to recognize the ethical and medico-legal challenge in clinical AI, to understand how AI improves patient access and communication, to discuss how physicians must lead, not just adopt all integration, AI integration. I like this word by a French surgeon, an oncologist, who said, "The future is not the augmented physician. The future is the the future is not the automated physician. The future is the augmented physician." It's Bernard Norlinger. Keep in mind, when we had a stethoscope, we extend the auscultation. When we have all the tools in imaging, CT, MRI, we extend the vision. When we start the genomic, we extend the biology. With the AI, we extend the reasoning. The new patient reality, every week before meeting us, for OpenAI, one of the leaders of AI, have 200 million requests every week from patients before seeing physician. So keep in mind that before seeing you, many of the patients already had the ChatGPT answer. Yes, it could be an opportunity. Patients arrive better informed. AI extends specialist reach to understand population worldwide. The risk is misinformation, anxiety, self-diagnostic error. Physicians must lead this conversation with nuance, evidence, and empathy. The healthcare revolution, AI is transforming every layer of medicine simultaneous. Diagnosis, research, drug discovery, documentation, population health, patient communication. No other technology has touched every single layer of medicine simultaneous. AI in medical imaging, radiology, the first field fully transformed by AI, breast cancer screening. Now the sensitivity exceeds expert radiologists in population screening. Lung nodule detection, subcentimetry detection earlier than human review. Intracranial hemorrhage, near real-time triage in emergency setting. Diabetic retinopathy, FDA-approved autonomous AI diagnosis. Cardiac imaging, autonomous ejection fraction, wall motion, valve assessment, stroke detection, reduce time to treatment in acute stroke protocols. Some institutions argue not using AI in radiology could become a standard of care issues. Predictive medicine, from reactive care to preventive intelligence, medicine is shifting from treating disease to preventing it. There's a team of Stanford, they do a sleep FM, which is they study the patient when they sleep. And 1 night of sleep data predict risk of Parkinson, dementia, CVD, stroke, and cancer. Sleep becomes a biological language AI can read. And many other, they can read of AI in oncology. I am medical oncologist, so I like to see what happened. Interrogation tumor at molecular scales. 50 million cells AI analyze entire tumor microenvironment simultaneous, impossible for us for human review. Resistance mechanism model explain why tumor evade the immune system at the molecular level. Drug target discovery, identify new therapeutic targets from patterns across millions of patient data set. Digital twins, virtual patient model test, treatment strategy before real world application. Drug development, it took 10 years. The cost of drug development is huge, 2.5 billion. And AI can fundamentally accelerate this and also probably cheaper. You have to see AI as a co-pilot. AI proposes, the physician decides. Never let AI decide for you. AI analyze, patterns recognition, risk stratification, treatment options. You, as a physician, MD decides clinical judgment, patient value, contextual vision. And after that, probably we will have better care. Physician must understand when AI is used, why the recommendation is made, when to override it. Responsibility remains human always. AI makes mistakes, and in medicine, mistakes matter. This is why the right mental model is not autonomous medicine. It supervises, accountable, clinician-led augmentation. The bias, skill, and fairness. Model trains on a bias dataset can amplify inequity at population scale. Privacy, data trust, patient data require consent, governance, security, and sovereignty. This cognitive atrophy, overreliance can erode human diagnosis, sharpness, and vigilance. Black box, opaque logic, clinical adoption require transparency and the ability to challenge output. AI can generate a diagnostic, a summary, a risk score, a treatment suggestion. What it cannot do is predict the downstream consequence of being wrong for this specific patient in this specific life context at the specific moment. Again, AI propose, the physician decide. That is the ethical core of safe clinical AI. No algorithm replaces this, but AI gives us something priceless: time. Time to listen deeply to the patient in front of you. Time to think beyond the algorithm with nuance. Time to care for the human, not just the data. AI and health equity. AI can be the great equalizer if designed with equity as a first principle. Multilingual support, AI translates medical explanation instantly and accurately into any language, removing barrier for more than 5 billion non-English speakers. Pre-consultation prep, patients receive AI-generated summaries before their appointment, arriving better informed and with structured questions. Result interpretation, patients understand the labs and imaging result with AI guidance, reducing anxiety and unnecessary callbacks. Remote access, AI brings specialist-level guidance to rural and underserved communities. Geography becomes less a barrier to expertise. So, I give you a lot of theory, enough. Let me show you what we are building today at MUHC and the McGill network. This is not the future, this is now. The scarce resource in oncology, it's not drug, it's not machine, it's physician attention. You can't imagine how many hours on the day we spend to answer call, to do paperwork, insurance paperwork, to answer, our clinic is horrible. So we spent 20 years studying of being expertise. And after that, we are like every day, we spend hours on administration. It's a time stolen from thinking, deciding, and caring. This is the beginning of my story. When you see 3 years ago, my daily days, when I arrive, the issue is not the workload, the issue is the signal bird in the noise. On the blue, you can see my normal life, but on the orange, what I should not do, it's administration. And you can see how many orange on my daily life as an oncologist. 3 voicemail, unclear urgency, voicemail for a patient, call from ER urgents, I don't know, 6 message from the nurse, drug approval from a pharmacy, colleagues with complex case. The last voicemail, this is the last one, which is very important, but I'm not aware, I received too many. It's like a nose, my clinic. This day, like 3 years ago, I was looking for a solution. So looking, going everywhere. This was the beginning of AI. And I find friends and colleagues that was working in a small company. And I asked them if they will be able to help me. And they said, yes, we can. And we start to begin with, I'm more francophone, so mon intelligence artificielle assistant that I called at the time Mia, that was taking my phone call. And she started to be very, very, very nice and very smart. So after a few months, I changed her for Amanda. And you would ask me why a female, why a name like that. I can explain to you why. But I have another partner in AI, which I call Ben, and he was a male. Also, I will show you what they are able to do. So before Amanda and after Amanda, you can see how my life was. Before 2 and 3 hours listening to voicemail daily, urgently unclear, everything feel urgent, callback, interruption, consultation, clinical info scar across message, cognitive overload by 11 in the morning, important signal lost in routine noise. After Amanda, today, AI answer call 24 hours, 7 days, with empathy. Urgent triage in real time, you see it first. Structured clinical summaries waiting for you. Urgent cases flagged with priority score. 0 interruption during consultation. Time available for you for thinking, for research, for sitting, for your patient. This is a search of Amanda, which is not a chatbot. It's a clinical infrastructure. Answer with empathy, flag priority, triage urgency, generate clinical summary, learn from clinical workflows. My Amanda is not the same as an ENT surgeon. She's learning with me and she's becoming with me, like little bit like me. I will show you with some 2 tests. One is a physician playing a patient. And as you know, I am breast oncologist. So Amanda knows very well breast cancer. And you will hear in this conversation why Amanda is trained by me. And the second one is an ENT surgeon that is used to call me. And he's surprised to be with the AI, but he's happy and he wants the same. So it's very important to convince when you bring a project in a new project like that. So let's do a break of me and let's see Amanda, how she takes my call.
Hi there, Jamil's AI secretary speaking.
Hi, how's it going?
Oh, hi. It's going well. Thanks. Who's calling, please?
Are you an AI bot?
Yes. Guilty as charged. But hey, I'm here to help Dr. Asselah stay on top of things. May I know who I'm speaking with?
What's the name of your company?
Well, I don't belong to a company per se. I'm directly here for Dr. Asselah, Montreal's top oncologist. Some say the funniest too. May I ask who's calling?
Which company designed your software? I want the same
Oh.
software for me too. I'm a doctor as well.
Ah, a fellow doctor. Nice. Well, I'm a custom-built AI assistant designed specifically for Dr. Asselah. My software wouldn't really be off the shelf, if you get me. But hey, what's your specialty? Maybe you and Dr. Asselah can connect about it.
It's okay. Thank you. Bye-bye.
We can see the frustration of my ENT colleagues. And now the physician is playing a patient. I will try to play that.
Hi there, Jamil's AI secretary speaking.
Hello, where is Jamil?
Oh, Dr. Asselah is tied up in the moment, but good news, I'll make sure he knows about this conversation right away. May I ask, who's calling?
A guy called Tarek. Do you know me?
Oh, Tarek. Sounds familiar. Can you tell me a bit more? Are you a patient, a colleague, or maybe a friend of Dr. Asselah?
I'm a patient of Dr. Asselah and I have a health problem.
Oh, of course, Tarek. I see. You're one of Dr. Asselah's patients. I'm sorry to hear you're dealing with a health problem. Can you tell me a bit more about what you're experiencing? Any symptoms or concerns you'd like us to note?
So I'm short of breath and I don't know what to do. And he called me quickly.
Oh, I see. You mentioned the brass. Did you mean breast? Are you experiencing any pain, swelling, or changes there? Take your time and I'll make sure Dr. Asselah gets the full picture.
I'm short of breath and I have chest pain.
Oh, Tarek, I'm so sorry you're feeling this way. Shortness of breath and chest pain. That sounds serious. Are these symptoms new or have they been happening for a while? And is the chest pain sharp or does it feel more like pressure?
It's been happening for 1 hour and the chest pain feels like a pressure on my chest.
Oh, I understand. That sounds very uncomfortable. I'm really sorry to hear that. Given that it's a recent development, it's important to get immediate attention. Have you considered going to the emergency room just to be sure? Dr. Asselah will definitely want you to be safe.
I don't know. Should I go to the emergency room?
Given your symptoms, Tarek, shortness of breath and chest pressure, it's really important to err on the side of caution. I would strongly recommend going to the emergency room as soon as possible. They can provide immediate care and make sure everything's okay. Dr. Asselah would want you to be safe and get checked out right away.
Okay, will do. Thank you very much.
Oh, you're welcome, Tarek. Please take care and head to the emergency room right away. Wishing you all the best.
She's very polite, very empathic, and it was pretty right, you know.
Hi there.
So this was Amanda. So the ethic first, you know, before launching Amanda, it was very important for us to work with the Collège des Médecins, responsible AI required regulation partnership from day one. So we are working with the Collège des Médecins du Québec, and we choose to engage with them proactively before deploying Amanda to ensure that every aspect of the AI met the highest ethical, clinical, and legal standard. Patient consent and data use reviewed, clinical liability framework clarified, transparency of AI decision-making validated, equity and access review for all patients. And today, I want also to thank again the CMQ for its collaboration and recommendation. And we were so proud of Amanda that we were presenting Amanda everywhere. And one of the very important people told me, if I ever have a medical problem, I would want to call and speak directly with my physician. I was listening to her and I replied, I said, the reality is that the majority of patients call and nobody can answer. I would rather have Amanda there for them. You know, of course, if you are a physician on the phone, it will be perfect, but the reality is not there. The personal impact, why Amanda changed in my practice, immediate, measurable, sustainable, 2 hours recovering every day, 68% reduction in unplanned interruption. And we have 2 projects when we plan to put Amanda with patients who are taking one of the drugs in breast cancer. And according to our statistics, we plan 84% of adherence using Amanda for the treatment to 68% without someone who followed the patient. So it's very important, but because you can have the best drug, if the patient are not taking the drug, it's not useful. So, and also during the night and during the weekend, we have this voicemail that patient call. So by putting Amanda on this voicemail, we plan to reduce by 45% the emergency visit during the night and the weekend. What used to take hours now takes minutes. Urgent case appear first. Routine requests are filtered, spam disappears, and suddenly something remarkable happens. Physician get their time back. Better prioritization, less cognitive overload, more presence for patient. And this is very, very important for us to be there for our patient. We have 7 AI projects in Quebec that we want to launch and we start to work on with our network, which is the McGill network, a breast cancer network in Canada. It's to build AI as healthcare infrastructures. One of the projects very important for us is the clinical trials, because for us, clinical trials, in North America, only 3% of patients are included in clinical trials. So it's like a closed thing, no one knows what is available. The physician outside the big center don't know, and patients are not aware at all what is ongoing. And there's so many opportunities now today for new drugs. It's a shame to not be aware of clinical trial. It was a priority to build a multi-language AI assistant for clinical trial, working all the time, and it's available now for our patients, in breast cancer at least. The toxicity, because it was very important for our pharmacovigilance to know if a drug caused an issue to a patient and to report that. Oncology triage, like I show you, Amanda taking care of patients on the night, on the daytime, very important. Radiation side effects also. We want automatic symptom triage line in case. The pre-consultation, like when you travel, 24 hours before seeing your physician as a new consult, you can connect with the AI and talk to the AI, all the antecedents, and the physician will collect all this information half an hour before seeing you. Colorectal screening, we work with our GI team here at MUHC to do the colorectal screening. Sarcoma, it's very important surgery and to prepare the patient before and after. I will show you again a short video to show this project again and to.
AI is transforming medicine every day. But what if AI weren't just a machine, but a presence? In Montreal, 7 groundbreaking AI projects are reimagining how we care. Not to replace us, but to amplify us, so that every patient and every voice is heard.
Hello. I don't feel well. I think I need help.
Making medicine more human through artificial intelligence.
It's a turn, it's not me. So our vision is AI designed by clinicians, and this is very important also, not imposed on clinicians. If we don't do anything, trust me, Google, OpenAI will come to us to sell us in few years $1 billion expensive, and this is only built by engineering, not by physician. Architect physician must be the architect of medical AI, not passive end user as already reluctant adopters. Protect clinical ethics must guide design, equity, privacy, safety, and informed consent must come first. Validate AI tools must be validated in diverse patient population before deployment at scale. Educate physicians must understand AI well enough to know when to trust it and when to override it. I was talking to you about the clinical trial. You know Amanda and you will know Ben. Ben is our AI that we developed for clinical trial. Patient can call, physician can call Ben, plain language access to trial, physician facing, surgery pre-screening, impact, access, transparency, scalable. Anywhere where you are in Quebec or in Canada, Ben will be able to show you which center to go, which team to contact, and Ben is able also to do a pre-screening for any kind of ongoing study. And Ben is connected also to the big database in US. In case of you have a very rare breast cancer, Ben is able to also tell you if you are eligible on the study. You can try this line. You can play patient, physician. It's working very well. I will show you one of my residents who called Ben for a real patient, and you will see that it was not so bad.
McPeak Siroy's Group for Breast Cancer Research. This is Ben AI recording. Hello.
Hi, Ben.
Hi there. How can I help you today? Are you a patient or calling as a clinician?
I'm calling as a clinician for a patient.
Great, thank you. How can I help regarding your patient? Are you looking for clinical trial options?
Yes, exactly.
Perfect. Can you tell me your patient's diagnosis and prior treatments? I'll match trials for you.
So I'm seeing this 36-year-old patient who had inflammatory breast cancer treated in 2023 with chemoradiation, who is currently on adjuvant anastrozole and abemaciclib since approximately July 2024. And she has developed new metastatic cervical adenopathies that were biopsy proven to be ER positive 90%, PR negative, and HER2 negative breast cancer. So I'm looking for a clinical trial that's possible for her.
Thank you. Has she received any prior endocrine therapy or only anastrozole? Any prior CDK4/6 inhibitor before abemaciclib?
I don't think so, but I don't have that information clearly in the chart.
No problem. Do you know if she has any PIK3CA mutation testing done? And is her organ function stable?
Her organ function is stable. I don't believe new generation sequencing testing has been done on her.
Thanks. Would you or your patient prefer a specific location for trial participation?
You can see the precision. We just put the inclusion criteria and the exclusion criteria on the machine and the algorithm. And it's very natural. If you can find the same information by spending 2 hours on Google, PubMed, clinicaltrial.gov. So the real question is, who shapes AI in healthcare? Technology company or physician? The answer matters for every patient. If we don't shape it, AI designed for efficiency, not clinical nuance. Algorithm trained on billing data, not outcome. Liability unclear. Physician bear risk they didn't create. Patient-physician relationship mediated by tech companies. Physician become data entry clerk for AI system. If you guys, physician, healthcare professional, lead AI design around clinical workflows and outcomes, algorithm trains on real patient data with physician oversight, liability frameworks built with medical expertise, technology that amplify the physician-patient relationships. Physician remains decision maker, AI handle the noise. Amanda was built by an oncologist for oncologists. Clinical nuance cannot be outsourced. In all this project, what is our vision for AI here at MUHC, Quebec, and Canada with our network? We decide because we have 4 main problems in our daily practice. We don't have the report of our CT scan. We don't know if patient is progressing. We don't know what my patient have. We don't know if our patient is eligible on clinical trial. We have all this new drug with QT2 monitors. And we love our colleagues cardiologists, but do we have access the same day when the patient is doing the EKG? No. So we want to have help in this setting. The pathology, we are finding some biomarkers, but it takes a long time to have. Also, the T67, which take time for our pathologists. The drug reaction, the skin screening, when the patient have a toxicity, we don't know what to do. We send them to specialists, but we have to wait. AI will not replace the specialists. We are not replacing our radiologists. We are not replacing the dermatologists. We are not replacing the cardiologists. We want the expertise. We want our patient to see our colleagues. But what we are working on today is the future Amanda, a version of mine connected with my smart glasses and to read what was impossible in the past.
And tomorrow, for Whites, even further. A world where care meets intelligence. Where Amanda, the AI assistant, lives not in a screen, but by your side. Through smart glasses, she sees what you see. In dermatology, she whispers instant truth from every skin lesion. In radiology, she reads images in real time, turning pixels into meaning. In cardiology, she decodes every heartbeat, as if listening to the soul. In pathology, she interprets each slide alive, revealing what the human eye might miss. Amanda, not just artificial intelligence, but augmented humanity. Always learning, always caring, always by your side.
Wrong question. Will AI replace doctors? This is not the question that matters. The right question is which physician will adapt, which physician will lead. That answer starts with you today. My message to you, McGill resident, medicine 2026, don't be a passive user. Using AI is the minimum. Leading its responsible development is the goal. You have what engineering don't. Clinical nuance, suffering, context, no algorithm was trained on that. Be a builder. The physician who shape AI will determine whether it serves patients or shareholders. Lead with courage. Innovation always faces resistance. Progress happens because physicians choose to lead. The future of medicine will not be built by machines. It will be built by physicians who know how to use them. Today, we are here in the MUHC, one of the Canada's most advanced medical campus. Imagine the MUHC in 10 years with the AI. MUHC plus AI, the hospital that syncs with you. Real-time diagnosis, AI reads image labs and vital simultaneous result in seconds. Genomic precisions, every patient matched to the exact therapy based on molecular profile. Predictive alert, critical deterioration predict before it occurs, nurse notify. Autonomous workflow, schedule, coding, and documentation handled by AI agent 24 hours, 7 days. AI guides oncology, tumor board unwanted, clinical trials match in real time, drug discovery on site, researchers co-create new molecules with AI in the loop. AI will not replace physicians. It will make them extraordinary. And we are doing a big event to show our project and to make other projects also. Save the date, the May 21 at the Centre La Science Racing for a Cure, Montreal Summit on AI and Oncology. We want to celebrate our 10th anniversary of our McPizzeria group. 10 projects, 10 million, 10 years of impact. First result of Amanda, what she's able to do. our 2 hours saved daily, 84% of patient satisfaction. We'll see, I hope. And another first project will be with our clinical trials, Ben. And we will have new projects with AI and tumor board, real-time genomic matching, predictive oncology, early relapse, and the augmented physician with the smart glass. Be the generation that change cancer care forever, just us. Thank you very much. We have time for questions.
Wonderful. Congratulations. This is really a next level. Thank you so much for sharing this with us. Okay, there's a lot of happy people online there. Okay, I will take questions. We do have time for questions. If there's questions in the chat, please enter them in the chat. Yes, Brave New World, Andre Dascal said. Fahimi Saud, I don't know if you want to unmute to ask your question. Otherwise, maybe I'll just
yeah, sure, you can ask
yes.
for me. It was just the place of AI and how does it see it in primary care. We've talked about all the specialists, medicine, but how about primary care, family physicians?
Yeah, I think it's a big problem in Quebec. We can see how many people come to the emergency. So primary care is very important. I think AI can answer many of the problems that, again, if patient go to ChatGPT is very subjective, meaning that I'm sick, I need to go to ER. ChatGPT will say, yes, you are sick, go to ER. If we build an AI that can be like in our algorithm, if you do algorithm in primary care and you put this AI before you appointment, I think it will be very helpful first to collect some data, some information, who calls, but a physician or healthcare professional will have to oversee all this data, all this information, but it will be a first triage and many of patients will have someone to talk. And AI will be able to know who is important to see or to call back. And I think this is a very important part of the AI solution in primary care.
Thank you. Catherine Weber, you have a question. Do you want to unmute?
Sure. Thank you. Very interesting. So I had a few questions just regarding the Amanda. When you played the video, I was just wondering, I didn't hear, I'm just wondering how patient consent's obtained, and then what actually happens to that data once Amanda is chatting with the patient. So where do you store it? Is it used to retrain the model? How do you mentioned you integrate the node into the MUHC systems. And then what about harm? I'm just wondering how you looked at those aspects.
Yeah, so the pilot project will start. We are in the phase of the working on all that. We work with our pilot patient also. So the patient are working with us. So the data are stored in Quebec. The government of Quebec, Collège des Médecins, refused that we store anything in the US. We understand that. So we don't have any issue to store everything in Quebec. On the nuage, and also yes, we learn with all the data that we collect how to do the future algorithm for the next generation of patient. The idea is to use both. For example, for side effects of chemotherapy, our nurse having the app with Amanda and patient call the triage. So the patient will call in the same time, the nurse after the patient call, see the conversation. And if there's any problem, any mistake, the nurse will call immediately after the conversation. But we are not expecting mistakes, but we've done that as a safety, for the 6 months. After 6 months, and we will do also the night also without nurse, but after 6 months. So the first 6 months will be only the daytimes, and after that. So the first time that Amanda talked to the patient, they can send them. So they can send a PDF by text message to the patient or just a text message. So we are working to see what is the best way. In clinical trial, we send a PDF that patient sign, but the real signature will be when the patient meet the clinical trial team. But it's like pre-consent. So we have at least a document that we can put. After that, the communication, the integration with the system, we are working with Epic because I hope, I don't know when, but Epic will come at MUHC in Quebec. So we are trying to work with Epic now. We are not working with Oasis for now, but we want to plan the future.
David Rosenblatt, you want to go ahead with your question?
Okay, I put it in the chat, but it's the same issue we have in Quebec. How many years has it taken us to get EPIC or some sort of EMR? We can't get laboratory values in any sort of time on molecular tests, even into the system. You can't find information easily. The AI is wonderful, but how do you make it integrated, sustainable, coordinated with all the other activities happening provincially when everything is regulated from the top down? People tell you which systems you can use and which you can't. And we don't have the flexibility of making things long-term and sustainable.
Yeah, for now, the first step that we are working with radiation oncology. So with ARIA, we will find a way to integrate the data directly to Amanda, but we are just waiting Epic. We don't have any control on that when we expected, but we have a pilot project with radiation oncology to start that despite waiting for Epic.
Maria Riera, please. Dr. Arietta was asking about things like HIPAA, and especially in Quebec, I know there's things like TGV, HIPAA. I assume you have all this in place, and non-nominal information, can that bypass this?
Yeah, exactly. All the new technology need to go through all this new security governance thing. Yes, we are aware about that.
But if it's non-nominal, can it bypass that? If you have no patient information, can you bypass?
If you have the age, yeah, we can bypass.
HIPAA and TGV if you have no patient information.
I think so, yeah. I need to work on that.
Okay. Just going to go through, I think I have one last one. Dr. Doss, why don't we go to the room and I'll try to summarize this. Any questions in the room? Okay, I have a question for you. What is the cost of all this for you? Is it paid by the minute? Is it paid by the words? Is it paid? How does that, how do you cost this out?
So that's why we want to raise money, because we have many collaboration with many departments at the MUHC. So we want to raise one big amount of money, because the AI in the beginning, the searcher is one big money. And after that, all the algorithm, if you want to do oncology, cardiology, colorectal, is the same. You just have to change few things. So we have to pay some. Unfortunately, we are not able to work with research companies. So we have to work with the AI, a small company of AI, to build all this ecosystem. But for now, our pilot projects are not free, but we are developing. It's us that we work with this AI company, but you need to understand that this AI company, it's not with the free vision that they are working with us. They are very interesting to work to show that the models is working in a hospital like the MUHC. Like that, I imagine in future they will be able to sell it in a bigger scale, like in US. So that's why, yes, it's free for now, but not in the mind of these people with a small AI company for now, but looking for big market.
And are you looking for other groups to join? Are you looking for other teams to work with?
Oh, for sure. We are always open for project. So we welcome any project. After that, we meet our scientific committees. And of course, we never say no. And after that, we find a way of collaboration for win-win project.
So are you the contact person for that?
Yes, I am the contact person.
Okay. Any questions in the audience? I think I covered all the questions. Dr. Doss was talking more about that he believes AI could alert the physicians, the appropriate physicians, directly, right? That there's a possible link. Sasha Bernatsky wants to know, how did you train Amanda?
Yeah, so Amanda, I will not say some difficult words, but I use Amanda every day. It's many hours every day since 3 years. I'm my nurse, my resident, I use in Amanda. And each time someone calls, I receive the notification on my phone. So I review everything. And when I see a mistake, when I see an inappropriate answer, I ask Amanda, why you've done that? No, this makes no sense. Go on this paper to double check. No, don't answer like that. I have some colleagues, they don't want Amanda call them by the first name. So I ask Amanda, this person you call them professor, this person you call them doctor, this person you call them. So I train Amanda with me, but in the beginning, Amanda is connected to all the big AI company, OpenAI, Gemini, and etc. And we have some filtrage, and my colleagues who are engineers are like making the field. I am just here to design the vision, how I want Amanda give answer, how I want Amanda to interact with my nurse. But I have many, if you call me on my phone, Amanda will send to you. But if I know you, she will not be the same if I don't know you. If I don't know you, Amanda will tell you like a normal voicemail. Who are you? Do you want to leave a message, Dr. Asselah? But if you know me and if you call me a lot, Amanda will start to joke with you, will start to ask you about your boyfriend, your girlfriend, your dog, your grandmother. She will know it's crazy. When I listen some message from Amanda and my nurse, I don't know who is the AI at the end. It's crazy. I don't have time today to show you, but sometimes it's very, it's a little bit scary conversation.
Okay. So if there's no other questions, we will end there. Once again, congratulations, really exciting work. And thank you for sharing this with us. And I'm sure there'll be lots of takers to advance this further. So thank you. And thanks everyone online for joining us. It was